non-adjuvant anthracycline-based chemotherapy in local advanced breast cancer. Again, the introduction, work, patient, and the method, result, discussion, completion. Breast cancer is the most common malignancy among women worldwide, with nearly 1 million new cases each year. Among the Egypt National Cancer Institute, Syria 2001, it represents up to 19% of total female cancer cases. This is the breast cancer staging in Albania, Egypt. High stage, stage 3, stage 2, stage 4, and this one is stage 1. Local advanced breast cancer means large breast tumor mass more than 5 cm in diameter, T3, or direct involvement of skin or underlying chest wall or post, or inflammatory breast cancer, or extensive regional lymph node N2 or N3. And this is the breast mass, large breast mass, more than 5 cm in diameter. And this is for extension to involving the skin and extension to involving the chest wall. And this inflammatory breast cancer. And this is N2 nodal status of the local advanced breast cancer. N2 mean bulbable lateral axillary lymph node fixed to the one or another or to other structure. N3 denoting the presence of metastasis in the ipsilateral infracervical lymph node. N3B metastasis in the ipsilateral internal memory lymph node and the axillary lymph node. N3C metastasis in ipsilateral supraclavian lymph node. And this is true. The local advanced breast cancer mean 2B, 2-3A, or 3B and 3C. And the classification of local advanced breast cancer may be operable at presentation or not operable. Inoperable. Operable means stage 2B or 3A. Inoperable means stage 3B or 3C. Local advanced breast cancer represents up to 20 of the cases in the US versus 75 in the developing countries, and the high incidence might be attributed to demographic factors such as low education, low socioeconomic, poverty and lack of health and insurance, psychological factors, severe anxiety that correlate to fear of diagnosis. Management of local advanced breast cancer takes several years from single modality to dual modality to multidisciplinary treatment. Management of local advanced breast cancer surgery alone may decrease 5-year survival up to 36%. Radiation therapy alone 29%. Surgery plus radiotherapy 33%. 5-year survival rate. Addition of neoadjuvant chemotherapy up to 63%. Neoadjuvant chemotherapy refers to post-diagnosis systemic therapy, down-staging therapy, induction therapy, perioperative systemic therapy. Advantage of neoadjuvant and disadvantage of neoadjuvant chemotherapy. Advantage reduction in the tumor size, in vivo assessment of tumor response, less extensive surgical section, post-surgical cross-propagated, early induction of systemic therapy, down-staging, clinical and radiological staging ample size, overtreatment of small tuberous tumor, loss of prognostic significance of axillary lymph node, large number of drug-resistant present cells. Indication of neoadjuvant chemotherapy in local advanced breast cancer for inoperable to be operable and operable to bridge to breast conservative surgery. Neoadjuvant chemotherapy may be CMF or anthracycline or anthracycline combination with taxane. Pathological complete response with CMF less than 10% and long-term survival up to 20, but in anthracycline plus taxane, pathological complete response up to 40 and long-term survival up to 60. This is anthracycline. Mechanism of action for anthracycline 2A inhibition, enhancement of catalysis of oxidation reduction reaction, and DNA and RNA inhibition. Toxicity from anthracyclines is cardiac toxicity and it is the most frequent. 5% of cancer patients which are resistant to neoadjuvant chemotherapy, especially the anthracycline-based chemotherapy, unnecessary side effects may be avoided if biomarkers of response are identified prior to treatment. 2-isomerase enzyme. 2-isomerase are molecular and nuclear enzymes that involved in resolving cell problems that arise during the various processes related to DNA metabolism, which including transaction recombination, replication, and chromosomal segregation during cell division. Types: type may be type 1 and type 2 according to their catalytic activity. Type 1 introduce transient single strand break into DNA, pass single strand of the DNA through the broken one and relocate the breaks. Type 2 turn transient double strand break into one segment of the replied DNA and pass in an intact duplex through the broken double strand breaks. And this is a 2A. Mechanism of action 2A is essential for anchoring of DNA and make double-stranded breaks in the DNA, and DNA will become pass through the breaks, and the 2A regulates the free ends. And this is the 2A action. 2A inhibition also include anthracyclines, etoposide, amyloidopathy, methylphenidone, trapping of 2 alpha in covalent bonding, reversible complex with DNA, terminal cleavable complex. Stabilization of cleavable complex prevents the realization of the double-stranded breaks, leading to conversion of 2 into physiological toxin and induce high level of permanent double-stranded breaks in the cell eliminated by apoptosis. This is the action. This is the 2 inhibition, inhibitor catalyzing. This is block realization. This is permanent double-stranded break, and finally cell death. Histopathology: 2 has a gene and a protein. Gene can be detected by fish or fish. Protein can be detected by immunohistochemistry. Interpretation of 2 protein: more than 10% in the nucleus is positive, less than 10% is negative. This is the expression, low expression, overexpression. Whatever the gene, amplified gene on deleted gene, amplified gene mean positive gene, deleted gene mean negative gene. 2A amplification, 2A deletion. Aim of this work to evaluate the 2A as a predictive factor for response to neoadjuvant anthracycline based chemotherapy in local advanced breast cancer. 50 female patients with local advanced breast cancer were treated with neoadjuvant chemotherapy between January 2001 and June 2012 at the Department of Clinical Oncology, Stanford University Hospital. Inclusion criteria age less than 16, performance status, cardiovascular scale more than 70, echo, ejection fraction more than 60%, blood, adequate blood, renal and liver, and the chemotherapy no, or radiotherapy no, the chemotherapy. Pre-treatment diagnosis for biopsy of the primary tumor, or for all patient had a skin tattoo on the area of palpable tumor to help tumor localization after chemotherapy. For history, age, menopause, number of children, contraception, general examination, head and neck and upper limb, chest, abdomen, pelvis, lower limb. Local examination of the breast and axilla and the mass and size and shape and mobility. Laboratory code renal function and liver function and adequate blood. Metastatic workup, see the chest, pelvic abdominal ultrasonography for scan. Radiological bilateral mammo and the echo cohort available. Treatment of the neoadjuvant chemotherapy either by FAC or PEC. Assessment of the response to the chemotherapy may be clinical and radiological by certain criteria, pathological by satellite method. Complete response mean disappearance of alternate lesion. Partial response mean 30% decrease in the sum of longitudinal diameter of target lesion. Progressive disease 20% increase the size of sum of longitudinal diameter of target lesion. Stable disease neither the patient shrink or partial response nor shrunk. Satellite method pathological complete response mean total or mean total therapeutic effect. Pathological partial response more than 50% therapeutic effect. Pathological no response, no therapeutic effect. Histological evaluation, histological grading and histological types and hormonal factor ER, PI, HER2, 2A. Result of the study: age less than 35, 7, more than 35, 43, menopausal, premenopause and the postmenopause, premenopause 26 and the postmenopause 24, marital married 48, single 2. Clinical presentation: breast mass 44, breast scale lesion 6, clinical T2 36, T3 CLD, T4 1, clinical nodal N2 49 and N3 1. Stage 3A 42 and stage 3B 8, right breast cancer 25 and left breast cancer 26. Type: invasive ductal carcinoma 46, invasive lobar carcinoma 2, measurement 2, grade 2, 49 and grade 3 1. ER positive 34, ER negative 16, PR positive 32, PR negative 19. KI high, KI 16 and low KI 34, HER2 positive in 10 and HER2 negative in 40. 2 positive 44 and negative 5. This is the chemotherapy, this is the book, this is the med. Pre-neoadjuvant chemotherapy. These are the appearance of the med after chemotherapy. This is the before, the after. And evaluation in immunohistochemistry of macroscleral response show 2 positive in 45, 45 positive, 24 pathological partial response, and 3 pathological complete response. And conclusion, our data suggested that 2-E might be a potential predictive factor for response to neoadjuvant anthracycline-based chemotherapy and local responsive breast cancer, and this predictive value was significantly better with co-separation of 2-2 and the HER2 and the high KI and the negative hormonal receptor status. And recommended patients with local responsive breast cancer should have core biopsy plus immunohistochemistry from the tumor before the start of the neoadjuvant chemotherapy, and this might help in the validation of the treatment protocol. Also, patients with local advanced breast cancer should have done tumor validation before the start of the neoadjuvant chemotherapy to help tumor detection after response to the treatment. And from this slide, we need from the neoadjuvant chemotherapy benefits and less toxicity, and the benefits with no superiority, but we don't need no benefits, no toxicity, no benefits, no toxicity. And finally, thank you.
Did you use Herceptin and anthracycline together when you have HER2 positive and Homerus positive cases?
No, I can't use the HER2 Herceptin with the HER2. I just used neoadjuvant chemotherapy, FAC or FAC, but I can't use Herceptin as a neoadjuvant chemotherapy.
Thank you. Did you see any effect of marital status?
No, show any significant effect in this study.
Yeah, I was just wondering why it was up there.
No.
And yeah, so for people that have either excision or something, that's usually a marker.
Yeah. Before chemotherapy, before the neoadjuvant chemotherapy, we have a tool in the breast mass for localization of the tumor to show response before chemo and after chemo. And sometimes we need to pathological or clinical complete response with no mass. Sometimes with opening the surgery, we need the tool to show the size of the tumor.
Yeah, a tattoo is, it's
the usual. It's usual study in Egypt before any neoadjuvant chemotherapy. We show tattoo the patient.
A tattoo is okay, but I was just trying to say that a marker in, not on the skin. Yeah, it's certainly better.
Just localization, the skin by the tattoo, not a marker, tattoo.
But they sometimes using the wire localization.
Yes. We can use wire or I can use tattoo.
Yeah, a wire is
effective than tattoo.
Much better.
Yes.
Yeah. And could you explain the Satalov?
Method, yes.
Yeah, I've not heard of it before. Sorry.
We use Satalov method as a pathological complete response, histopathological response to the treatment, and they had two types: clinical response and pathological response. Pathological response, histopathological evaluation by Satalov method, and this is the study of histopathologist with me in the study, not by me.
Thank you.
Thank you.
Any more questions?